Hello, I'm Carsten Floor and I'm a consultant paediatric dermatologist at Guy's and St Thomas's Hospital in London. I initiated and led the British Society of Paediatric Dermatology Guidelines project on the use of oral propranolol in infantile haemangiomas together with Mary Glover and Leah Solman from Great Ormond Street Children's Hospital. Infantile haemangiomas are the most common vascular tumour in infancy, and despite their frequency and potential complications, there are currently no unified UK guidelines for the use of oral propranolol in these vascular tumours, and that is what we wanted to change. But before we tell you about the guidelines themselves, just to pick up background. Since 2008, when French dermatologists made a serendipitous finding that oral propranolol was highly successful in the treatment of oral propranolol in a few cases of complex infantile hemangiomas, oral propranolol rapidly replaced prednisolone in the treatment of these children. However, since there was no randomized controlled trial evidence to inform best management at the time, centers often adopted different management approaches. We therefore founded a task force within the British Society of Paediatric Dermatology to formalize evidence-based guidelines that many British colleagues with a special interest in infantile hemangiomas have contributed to over the years, and we're very grateful for their input. As a first step, we conducted a survey in 39 centers from 8 European countries back in 2014, including well over 1,000 cases of infantile hemangiomas treated with oral propranolol. The survey was then published in the British Journal of Dermatology in 2016 and highlighted the diversity in treatment approaches. For instance, a lot of colleagues performed extensive baseline investigations, including ultrasound scans of the abdomen and extensive blood testing, and regular blood pressure measurements were also done during treatment, as well as having a lot of differences in drug dosing. The results of our European survey, together with a systematic review of the literature, then fed into a Delphi consensus exercise and then finally the formulation of the treatment guidelines, which is what Leah Solman will tell you about now.
Hello, my name is Leah Solman and I'm a consultant in paediatric dermatology at Great Ormond Street Hospital. With these guidelines, we aim to unify and simplify the treatment of infantile hemangiomas across the UK and beyond, and provide guidance on previously identified uncertainties. Indications for starting propranolol include periocular, airway, nasal, lip and auditory canal hemangiomas causing or likely to cause functional impairment, hemangiomas likely to cause permanent disfigurement such as facial hemangiomas or ulcerated hemangiomas, then spinal cord hemangiomas and selected liver hemangiomas. Relative contraindications for treatment with propranolol include heart rate or blood pressure outside normal range for age or frequent wheezing. In these cases, treatment needs to be initiated together with a pediatrician. Absolute contraindications include second or third degree heart block, hypoglycemic episodes and hypersensitivity to propranolol. Before starting propranolol, a prescribing physician should take a thorough history and do a comprehensive physical examination. Clinical photographs should be done to monitor treatment progress. Parents should be given information on propranolol, possible side effects, and also patient information leaflet. You're welcome to download the patient information leaflet based on these guidelines from the BSPD website. A pre-treatment ECG is not required routinely, but it's done in patients with heart rate outside normal values for age, strong family history of sudden death and arrhythmia, loss of consciousness, and in maternal history of connective tissue disease. Pre-treatment echo is required in infants with a heart rate outside normal values for age, heart murmur, and in infants with segmental infantile haemangiomas of head and neck. We have provided normal values for heart rate and blood pressure in our paper. Baseline glucose is required in infants who are preterm, small for date, feeding poorly, or have history of hypoglycemic episodes. Treatment with propranolol can be initiated on an outpatient basis without monitoring of heart rate or blood pressure in patients who are older than 4 weeks, with no significant comorbidities, with normal birth weight, born at term, with established feeds and appropriate weight gain. The starting dose of propranolol is 1 mg per kilogram per day in 3 divided doses. This can be then increased in 24 hours to 2 mg per kilogram per day in 3 divided doses. We recommend using 5 mg in 5 ml solution, as this preparation is least likely to be associated with dosing errors. In patients who are younger than 4 weeks, preterm, with faltering growth, feeding difficulties, or significant comorbidities, the dose of propranolol may need to be adjusted. In such circumstances, the recommended starting dose is 0.5 mg per kilo per day in 3 divided doses. The individual dosing regimen is done to the local pediatrician or dermatologist. These patients require admission for 2 to 4 hours. Patients with segmental infantile hemangiomas of head and neck and suspected phases association pose a distinctive treatment challenge, as they usually require prompt treatment of their periocular or airway hemangiomas. But in these patients, propranolol may increase the risk of stroke if arterial anomalies are present. All patients with segmental infantile hemangioma of head and neck require cardiac assessment, including echo and ECG, before starting the treatment with propranolol. Ideally, an MRA of head and neck should also be done before initiating propranolol. If an urgent MRA of head and neck is not possible to obtain, then the starting dose of propranolol should be no more than 0.5 mg per kilogram per day in 3 divided doses. The patients should be reviewed after 2 to 3 months after starting the treatment, or sooner if needed. The dose of propranolol should be adjusted for weight gain at either clinic appointments, by the GP, or by the parents with written instructions. After the initiation of the propranolol, a total daily dose can be divided in either 2 or 3 doses in patients with non-segmental hemangioma. Propranolol should be temporarily discontinued if the patient has wheezing that requires treatment, or in the setting of decreased oral intake. Treatment of infantile hemangioma should extend beyond the proliferative phase to avoid the rebound growth. In most patients, it's safe to discontinue the treatment at the age of 12 to 14 months. Weaning of the dose is not required. As you can see, we have radically simplified the prescribing of oral propranolol for the patients with infantile hemangiomas. We hope that our guidelines will help to standardize the care of these patients, not only in the UK, but also beyond. Thank you for listening.